Good evening, everyone. I hereby welcome you all, and we take a great pride and pleasure in bringing you the sixth series of the educational program Advanced Classes in Dentistry. This program shall be conducted with our esteemed speaker, Dr. Hussain S. Basma. This educational program is brought to you by FDC Limited, makers of the Fleming Lab. Therefore, on behalf of FDC Proxima, greetings to everyone. As you know, FDC is a fully integrated pharmaceutical company. Today, FDC carries forward the flaming spirit of its first dream, achieving accreditation from the US FDA, UK MHRA, MCCRSA, and the UAE, to cite a few. Over a decade, FDC is very strong in building capabilities of antibiotics, including the illustrious brand Flemiclav, a brand of co-amoxiclav. FDC has also set up globally approved multi-location manufacturing facilities for the active pharmaceutical ingredients as well as finished dosage forms. FDC markets more than 300 products in India and explore many of these to over 50 countries. FDC strives to explore, innovate, and integrate solutions with modern technology, empowering talent, and expanding healthcare horizons for a better quality of life to millions globally. Now, I take this opportunity to introduce and welcome our esteemed speaker, Dr. Hussain S. Basma. Dr. Hussain S. Basma received his Doctor of Dental Surgery from the Damascus University in 2009 with a full scholarship. Dr. Basma completed a residency in prosthodontics at Lebanese University and received a certificate in periodontology and a Master of Science from the University of Alabama at Birmingham. Dr. Basma is a diplomat of the American Board of Periodontology, lectures nationally and internationally about the periodontology and dental implants, and is a dental social media influencer. Dr. Basma is an assistant professor in the Department of Periodontology at UAB. His research and teaching efforts focus on bone augmentation, full arch rehabilitation, multidisciplinary care, and integration of technology. It's an honor to have him with us on this platform. I now request Dr. Basma to enlighten us on the topic of digital dentistry, a paradigm shift.
Thank you, Aman, for the nice introduction. Good morning or good afternoon, everyone, depending on where you are. Today, our lecture is going to be a completely different topic than the sixth time that we talked about, because we are living now in the digital era. So the talk about today is going to be digital dentistry, a paradigm shift. When we say a paradigm shift, we're talking about a complete shift in our practice that's made to ease our life, that's made to make our life simpler and to guide us in a more predictable way. I'm not sure if there's anybody who's young enough to not know what's that phone on the left side, but that's definitely the cell phone that we used to use, at least in my era, which is like 10, 15, 20 years ago. Then we moved into a more pronounced or more advanced technology, which is this Motorola that you see in the middle, which is actually has a long antenna and it's very heavy, but it didn't have any other functions other than calling wireless. And then we moved into today's phone, which is a complete shift, where we're now accessing all the world, actually accessing all the news, the information, all the social media from our cell phone. So we moved completely in a digital era, and now our life is way easier, our life is way simpler. We can control our bank account from our cell phone, we can control our house entrance from the cell phone, we can literally FaceTime anyone throughout the whole world. So this is a really very interesting era that we're living in. In dentistry, we used to take a full mouth series. The full mouth series gave us a lot of information, right? It gave us a lot of information about the root canal, if there is any periapical lesion, if there is decay, if there is bone loss around the teeth, if there is a poor endo treatment, if there is a poor or ill-fitting crown, if there is a bad post, as you see right here, and if there is any pathology that's going on. The same with panoramic. We used to take a full mouth panoramic. We used to take a panoramic X-ray and a full mouth series in order to try to combine to see if there is any periapical lesion, if there is any pathology, if there is any tooth problem. So that's the reason why we used to take these two images. But you know what? We are now in the digital era, and as much as these two images that we used to take help, but still we are lacking a lot of information. Why? Because these two images are actually a 2D X-ray. When we say a 2D X-ray, especially in different kind of dentistry or fields of dentistry, we are incapable of recognizing the amount of bone, for example, that we have in order to place implant. We are unable to to locate the limits of the pathology. So we needed always a 3D X-ray that would help us to examine exactly how much bone do we have. Because again, it's more about getting more information and being able to understand the etiology to give a good diagnosis in order to give a very good treatment planning. So when we talked about digital dentistry, definitely we are bringing new terminology that we're going to utilize in digital dentistry. Now we have different terminologies or new terminologies such as DICOM files, and we're going to talk about this in just a little bit. We have the STL files. Also, we're going to talk about that. The CAD-CAM, which is the printing. We have the voxel. We have the CAS, the pixels. All these are terminology that are very new, and I bet all of us know it now because we know that what is pixels, because we know all have cameras. We know what's pixels. We all have CBCT right now. That's why we know what's DICOM files. So all these terminology actually came in, and it worked really well with us. But definitely what's more important is that we have to understand exactly what is the workflow that we are used to do nowadays in our daily practice. So let's say if a patient actually come to us, and then we're going to understand all of this in just a little bit. So when we talk about digital dentistry, it's basically trying to ease ourselves by gathering a lot of information from two scans, one from the intraoral scan, the other one is from the CBCT. We gather all the information, and then after we gather the information, we start planning the case in a software that we definitely will try to fabricate our provisionals, that we try to also place our implant guided, and then after the implant heals, we try to take a digital impression, let the whole thing heal, and fabricate a temporary prosthesis, and then at the end also print the final outcome. So it's very important to know that in order for us to be successful, we have to have a good data acquisition. When we talk about a good data acquisition, is basically we're gathering two things. One is called the CBCT, which is the cone beam computed tomography that we all know as a 3D scan. Right? So one of the most important thing for a 3D scan, it's actually give us a three-dimensional image that allows us to have small sections or segmental sections of informations that we can gather together in order to come up with a plan. And usually whenever we are dealing with the cone beam CT scans, those small images that we gather are called DICOM files. So if we take this patient right here, and actually this is a true story, this happened actually in my clinic. This patient presented that she doesn't want to go with a vertical regimentation on both sides of the posterior mandible. I took a look at the panoramic. I was like, listen, ma'am, you were referred here for Olonex. I don't think this is a good idea. Let's go ahead with doing a vertical regimentation on both ends. And the patient declined that therapy because she didn't have enough finances to support this treatment option. So we said, okay, you know what? It seems like you have a lot of bone in the front, in the anterior mandible. So maybe an Olonex might work in this case, which is very aggressive actually in this case. But let's take a 3D X-ray, which is a CBCT, in order to see how much bone we have. So when we took the CBCT, we realized how thin the bone is. In order for us to be able to place the implants in this patient, we have to remove all this bone, remove the teeth, in order to reach the basal bone in order to place implants, which is a very aggressive, unpredictable treatment plan. So we decided, you know what, we should go ahead and fit to the first option because we don't have enough bone. In the old days, if we didn't have the CBCT, guess what will happen? We will open, We will see that, we will realize, we will take the teeth out, we will plasty, and then we find no bone, then we close it up, and then the whole treatment now is messed up. So that's one of the powers actually of CBCT. And when we talk about CBCT now, the good thing is that we can have some radio-opaque markers that we utilize. For example, when we're planning anterior cases or when we're planning any implant case, we put a radiographic guide in the patient's mouth, and then we take an X-ray, a 3D X-ray that tell us exactly where's the location of the future prosthesis is going to be. And then we can do that if we want, or we can just do a digital wax-up on the software, and then based on that digital software, we plan our implant. Because if we look right here at these three images, okay, let's imagine that there is no restorative plan. Okay, that's what's the importance of this radiographic marker or radiographic wax-up or radiographic guide. Okay, let's say there is no radiographic guide in this case. All of these implants that we place right here in this direction, this could be an option, this could be an option, and this could be an option. So if we don't have what tell us which one is going to be the radiographic guide, actually which one, where the tooth is going to be, we're not going to be able to place our implant accordingly. So that's one of the importance of having a digital wax-up, a digital planning or radiographic guide during a 3D X-ray. And from there, we move into this case. This is a patient actually who presented to my office with a chief complaint that I want to have my number 8 restored. I don't know if you have the same numerical number, but let's keep it as a upper right central incisor. Okay, we already agree that this tooth is hopeless. We already agree that this tooth is non-restorable. Okay, but what's the first thing we are going to do? Usually we take an intraoral, a periapical X-ray, and I don't know if this is enough to place an immediate implant, because there is a lot of things that we should take into consideration when we're thinking about implants in the aesthetic zone. Are we going to place an immediate implant, or are we going to delay or use the conventional approach to place my implants? So in this case, we took an X-ray, a periapical X-ray that showed us that there is a big periapical lesion on this remaining root that we have. So placing an implant immediately here is a bit questionable without having a 3D X-ray. So we took a 3D X-ray in this case, and we realized that there is definitely an infection there around the tooth, or a periapical lesion that extends a little bit in the buccal aspect of that tooth, but we are still maintaining the buccal bone. But in some areas, that buccal bone, there is a small fenestration in the bone in the apical area next to that lesion. So we said, you know what, let's plan. We always don't give promises for those patients, right? We always tell the patient, you know what, I'm going to take this tooth out. Because I'm looking at this socket right here, it's a type 1 socket. When I say it's a type 1 socket, it's based on Dr. Joseph Kahn's classification. A type 1 socket meaning that this root, we have enough, that this root is facing the buccal aspect of the socket here, and we are able to utilize the palatal wall and the apical bone in order to be able to place our implants immediately. So in this case, what we did actually is that we are gonna do what we are gonna do. We were able to do a 3D X-ray that showed us all the information that we needed in order to decide whether we are gonna do immediate implants versus conventional, what is the length of the implant that we're gonna use, what is the width of the implant that we're gonna use in order to respect the buccal gap whenever we're placing our implants. So usually CBCTs helps in a lot of information gathering. Okay, we are able to now access all the TMJ. We are able to evaluate the TMJ. We are able to think about, okay, whether there is an impacted tooth, whether there is a pathology. We are able now to superimpose two X-ray together in order to see how much bone we gained, how much resorption we had, how is the pathology growing, or it's still the same, or it's shrinking. We are always also able to localize some anatomical features such as the nerve, the mental nerve, the IAN, the inferior alveolar nerve, and the sinus. And with the use of the CBCT, we're able to avoid a lot of problems, such as nerve injuries, such as sinus perforation, all these things that could lead to what? that could lead to some problems in our daily practice. So that's related to the CBCT. Okay, so with the CBCT, we're able to get something called, as I mentioned, we are able to get the DICOM files, and those are the readings that we gain from what? From the the 3D X-ray. The second part of data acquisition is called the intraoral scan. The intraoral scan is nowadays very new to a lot of offices, okay, but now we're utilizing this in our daily practice. And usually the intraoral scan is basically taking a digital impression for your patient. Instead of using the alginate, instead of using the polyvinyl siloxane, now we are able to take a digital impression that goes into the system, and based from that digital impression, whenever we take an intraoral scan, we're trying to get something called the STL file, which is exactly what you see right here on the bottom right side. So the STL file is basically a digital impression. But why it's an STL file? It's because it should be an STL file to allow the software that you're going to move this information to be able to read that those images. So it's basically a cloud of points that this intraoral scan creates, and it gathers it together in order to allow the software to read. So as we said right now, this STL file, that it's what is called the stereolithography, is what we're going to be taking from our intraoral images, our intraoral scanner. Okay, so once we have the information from this patient, which is exactly what the case that I discussed with you earlier on the maxilla right here on the left side, okay, the tooth number 8 that we talked about, we take also the tooth number, the bottom jaw scan, which is the STL file, and then we're also able to take the bite. So far from the CBCT, we are able, or the 3D X-ray, we are able to get the DICOM files. From the intraoral scan, we are able to get the STL files. And then the good thing is that we are able to implement, or we are able to move both files and into a software that allows us to superimpose both information together. When I say superimpose, that means the software will use the same information that are fixed in the patient, such as the teeth, for example. They were able to merge them together so that we are able to see both the soft tissue and the bone at the same time. How cool is that, right? So basically, now we are able to access this site exactly in the patient's mouth, where we are able to see where is the soft tissue, we're able to see where's the teeth, the adjacent teeth, we're able to see where is the bone, which is great actually. So now we are able to exactly place an implant in the patient's mouth virtually on the software. And then the good thing about that is that we are able to move that planning exactly as it is, where we like the implant to be, and move it into into the patient's mouth by creating something called a surgical guide, which is a guided surgery. So let's go back a little bit to this digital workflow and talk more into details about this. Okay, so we already know two things. We already know that for any patient that we're going to see in our practice, we are going to take an intraoral scan, we're going to take a 3D X-ray, and that is part of the data capturing or data acquisition. So from the 3D X-ray, we are able to get what? The DICOM files. From the intraoral scan, we are going to able to get the STL files. And both the STL files and the DICOM files are going to be implemented in a virtual planning software that allows us to place our implants virtually, that allows us to do our wax up, that allows us to do our whole planning setup. And based on that planning, we are able to do what? We are able to now fabricate a guide virtually on that software. And what the best thing is that we can literally export that STL file that we have and move it into a template, into a printer that we're able to have, that we have all in our offices right now, and we are able to literally print that guide. Now, what do we have? We have a surgical guide that we created based on a virtual planning setup, and we're able to place our implant in the patient's mouth virtually in a guided manner. So now I don't have to worry about any adjacent structures. I can trust my guides in 99% of the cases to go exactly where we are. We already planned it. Then after we place our implant, we are also able to do what? We are able to print our own temporaries. After we do a virtual wax-up, we're able to fabricate it provisional that's already printed with a PMA provisional or milled actually, and then we're able to provisionalize that implant that we did. After 3-4 months of healing, guess what's going to happen? We are now able also to take virtual impression actually by placing scan bodies, and then we take the impression of these implants and then we send it to the lab. The lab is going to digitally fabricate the final option or the final prosthesis that we have, and then we are already able to mill it and then give the patient the final outcome. How cool is that? From A to Z, we didn't take any impression. The whole process was guided. So let's move now into the clinical case that we already talked about. Okay, so again, this is Mr. X, who presented with a chief complaint that we have that he has to take care of tooth number 8 that chipped recently. We look at this case. Okay, if I'm looking as a surgeon, if I'm looking at the whole image, remember, I have to make sure that the patient is healthy to receive implants. I have to make sure that the patient has adequate soft tissue, which is in this case, he has tons of keratinized tissue, which is a great thing. I want to make sure that we are able to clean the defect and at the same time has a good type of socket that allows us to place our implant immediately. Okay, so that is the x-ray that I shared with you earlier. And that is a 2D x-ray that is very limited information, but it tells us that there is a very close root proximity. There is actually a big periapical lesion. So based on that, we said, you know what, let's take a 3D x-ray. We took a 3D x-ray, and again, as I saw on the 3D x-ray, I saw what? I saw a periapical lesion, and I want you all to focus on this. In that periapical area, there is a small fenestration, and you will see that in the digital planning. Okay, so we decided if we are able to clean the whole apical part and the lesion, we are going to go with the immediate implant option. But we told the patient this is also there is always a chance that this is not going to happen, and we are going to end up with what? With a conventional implant placement. Basically, we take the tooth out, we clean the site, we place bone graft, we let it heal, we come back and we place an implant. Exactly what we discussed. Number 2 is we took an intraoral scan that will give us the STL file that will, and then after that we are able to move the planning into the software that allows us with placing our implant, as you see right here, virtually. Now I'm able to place my implant. I'm able to fabricate a guide that that allows me to place the implant exactly as I planned right here into the patient's mouth. How cool is that? Okay, so but one thing that we realize is that in this apical area right here, where I'm pointing my pointer right here, is that there was a small fenestration where that lesion was. So we said, you know what? Let's not only fabricate a guide that allows us to place our implants only, but allows us to give us exactly the access of that software that was there, the access of that periapical lesion that we have there. So we said, you know what, let's do this. Let's fabricate a guide that have one axis for an implant placement and another axis for where the lesion is. Okay, definitely the software will create a prescription that we should follow that tells us exactly what's the implant depth, what's the diameter, what is the drilling sequence that we should follow in order to implement exactly the same drilling sequence or the same implant size. So we followed the same surgical steps as you see right here. So this is, we first tried the guide to see if it's seated and if it needs any adjustment, just to make sure that we have no shrinkage in the guide. We had no loosened guide. So we took the tooth out, and based on upon extraction, as you notice in figure number 5, you can see that the periapical lesion that we had came up with a tooth. But definitely this doesn't mean that we have only, now we don't need to clean more or to debride more the socket, which is the thing that we're going to do actually after every extraction. Now we took the tooth out, we checked the buccal bone is present, okay? And we place our implant guided, okay? That's a BioHorizons implant. We place our implant guided, and then after we place our implant guided, we fill that buccal bone, the buccal gap with bone. But in this case, we didn't have very high torque, okay? In this case, due to the bone was not very dense, due to certain reasons that didn't allow us to have a torque of 35 Newton centimeters. So we said, you know what? In order for us to preserve the soft tissue component around this implant, we're going to do something called a custom tissue former. So basically, when we talk about custom tissue former, or basically what's called the custom healing abutment, it's basically like you place the implant, you place a temporary cylinder, and then you do that with acrylic or with composite, where you're able to print the soft tissue by injecting composite inside that site and be able to fabricate a custom tissue former in this case. When we were done, actually, we were done with the first step, which is implant placement. Now we placed our implant, we preserved the soft tissue, and now we use the second part of the guide, which is exactly what we planned for earlier, is that we wanted to know exactly where that penetration of the implant is going to be, which is as you see in image number 21. So we were able to create a small axis that allows us to graft, place bone, place a membrane, and then close it up without affecting the soft tissue around the neck or around the area that we care about, which is the one that's adjacent to the implant or the tissue former or to the adjacent teeth. Patient came back. That's how initially he presented after 12 days. If you're asking what did we give the patient as a temporary here, we gave them an Essex retainer that doesn't touch this custom tissue former. And please note, after 12 days, how much bone graft apically we had already. That tells us how successful was our grafting at that moment. So this is the patient actually at 12 days. And then now the patient is still in the progress for healing, which allows us to fabricate and make sure that it is healing well. And now we move to the second steps that allows us to do digital impression, and give the patient the final prosthesis. So this is when it comes to very, very critical cases such as implant in the aesthetic zone. But what do we know now about full arch? Because we see a lot of full arch options, which is another option that we're going fully all the way in digital dentistry. So in digital dentistry, we are implementing in full arch, in All-on-X or prosthesis, in All-on-X options. Actually, we are implementing digital dentistry too. What does that mean? That means that now we're able to fabricate different kind of prostheses that allows us not only to place our implant guided, but also to do bone reduction, but also to pick up the denture without any alteration in the vertical dimension. So basically what we needed, and actually this patient has been consented to do that. The difference here is that we should definitely make sure that we are having two types of scans of 3D x-rays. There has to be something that allows the software to read on the denture, because the denture is plastic, it's not radio opaque. So as you see in this image right here on the left, in this video on the left side, that denture have small blue parts. What is that? Is those fiduciary markers, which is our radio opaque markers. So basically we put the radio opaque markers on the denture. We take a 3D x-ray for that denture, and then we put the same denture in the patient's mouth. We take another 3D x-ray, and then we merge those together. And now what do we have? We have, as you will see in this video, we are having those, based on those fiduciary markers, what do we have? This will allow the software to know exactly where the denture is sitting. As you will see, the software is calculating this. Those are the fiduciary markers that we put before on the top left, and those are the fiduciary markers on the top right, actually, that are in the patient's mouth. So now what the software is going to pick automatically or manually, and then look what's going to happen. The denture immediately sits exactly where it should be. So what does that mean? That means now I'm able to see the denture inside the patient's mouth. And this is called the dual scan. And it's very important to be able to do that, because Most of the time, if you want to go with this treatment plan, we have to have a guide, which is the denture of the patient's mouth. We can do that also guided, okay? And then we, based on this denture, we know exactly where the implants are going to be in the maxilla or and in the mandible. And most important thing is that we are able now to access this information by creating a surgical guide that allows us to place those implants guided. But if we want to go fully guided in the patient's mouth, actually, we have a certain process that we should go through, and that allows us to fabricate 4 different guides. One is the anchoring pin guides. So basically, if you look at the number 1 option, this is basically the patient's own denture. We do a duplicate for that denture, but we want to gather information from that denture where those pins are going to be. The pins on the apical part of that denture that you see in this image, where are those going to be? And then based on this anchoring pins that we already created, we're going to remove this denture that we already, number 1 guide, we're going to use number 2 guide. And that number 2 guide is going to be there throughout the whole surgery. What does number 2 guide do? Number 2 guide actually will follow exactly where we drill the first holes, the anchoring pin holes, okay? So basically, this is a bone reduction guide. So this is going to allow us to know what's the limit of the bone alveoloplasty that we're going to do. And then after we do the alveoloplasty, the 3rd guide that you see right here is the implant placement guide. Okay, what's going to happen? It is going to be seated on number 2 guide that allows us to place the implant. And then we take number 3 out after we place our implant. Number 4 is going to go on top of number 2. And then this will allow us to what? This will allow us to connect the implants to the denture itself with definitely a guided manner. So let's take a look about how things goes, okay? So this is a patient actually that has a maxilla that needs to be treated. Okay, patient has remaining teeth on the top. So we fabricated the first guide, which is basically seated on those teeth. But what does this guide helps is it helps us with know where are those anchoring pin drills are going to be. So basically, as you see in number 1, those anchoring pin drills, we go through it, okay? And then we take this first guide out, and then we open a full thickness flap, and then we place the number 2 guide, as you see in image number 2. Number 2 guide, as we discussed, is the bone plasty guide. So this guide will tell us how much plasty we are going to do. Now, as you see in image number 3, we already did the plasty based on the guide that we have in the patient's mouth. And then we move into the 3rd guide, which is the implant placement or the implant guide. So this is the 3rd guide. We place the implants guided in a guided way. And then after we place the implant in, guided, as you see in number 5, then we put the multi-unit abutments in number 6. And then after that, we put the cylinders in. We bring the 4th thing, which is the denture. Now the denture will sit on guide number 2. And then now we're able to pick up actually to pick up the denture. And we are able to fabricate a prosthesis from A to Z that we already designed prior to our surgical appointment. How cool is that? So you all see that digital dentistry is in our daily lives right now. Okay, we start actually by a single prosthesis to a full mouth prosthesis, and we're still able to implement those. And guided is not only for implants. Guided is now we're able to print our models. We're able to fabricate an Essex retainer. We're able to do a mock-up for the patient. We're able to design prostheses. You're able to design denture or print dentures for the patient right now. So all these are literally aspects of digital dentistry that is easing our life. It's making our life easier. It's definitely making our life more predictable, because guess what? Nowadays, a cone beam or a 3D X-ray is a standard of care. If you place implants, you have to have a 3D X-ray. Here in the United States, if you are placing an implant and you don't have a 3D X-ray and you got in trouble, guess what? You're going to be in trouble really bad with the boards because you didn't follow the standard of care, which is you didn't have a 3D X-ray to show you where the implant is going to be. So, or what are the anatomical structure that we have. So we are not only able to get the information, but we're able to execute the surgery, to be able to to do the surgery virtually in the patient's mouth. And we're able to implement those information and move it inside the patient's mouth in order to follow what we planned for. So our life is going to get more, and with guided surgery now we're able to take full arch impression for full arch cases in a digital way, and we are like the learning curve is very steep here. It's very steep. There's a lot of softwares that you can implement. There's a lot of information that you can do. You can be very creative actually if you are very good in digital dentistry. And I think the future is very awesome with this kind of treatment. Make sure you have a very effective planning. Make sure you have a good intraoral scan, a good 3D X-ray. Sometimes if the patient have a lot of implants, a lot of metallic porcelain crowns, this will create a lot of scatter. This could be a little bit annoying for the software to read. Make sure you have good intraoral scan, good 3D X-ray that allows us to merge in a virtual software. In full arch cases, you have to have a dual scan. And again, when we talked about the dual scan, there has to be like fiduciary markers that you place on those dentures. And you take the X-ray first, and then you move that same denture without moving the fiduciary markers in the patient's mouth, and then the software will be able to pick up the denture exactly where it should be in the patient's mouth. So all these information, and this is just a small glimpse of how big we can go in digital dentistry in a single implant versus a full arch implant. And I think with that, I want to thank you all. And I hope I didn't take much of my time, which I have, I think, 45 minutes. So if you have any questions, please go ahead and answer those questions. If you were shy to ask any of these questions, you know how to reach out to me via social media at Royal Periodontics, and I'll be more than happy to answer any questions. Aman, thanks so much for your help today, and I'm ready to answer any questions.
Well, with this, we have come to the end of this very educative and interactive session. And I'm sure the audience would have gained a lot from today's discussion. A big vote of thanks to Dr. Basma for sparing his valuable time and being with us. I would also like to thank our educational partners, FDC Limited, and CME partners, Spirent Communication, for conducting this webinar. So thank you, everyone, and have a great evening.
Thank you so much, Aman. Thank you, everyone who was present. And I wish you all the day until we meet on the next session for a new topic and new information. Have a great day, everyone.